So today we're going to talk about pre-hospital stroke assessment, and the objective of this lecture is really to simplify the screening process of acute ischemic stroke. Now we're talking about ischemic stroke, stroke caused by occluded blood vessels in the brain, not hemorrhagic stroke. And the first part of working up diagnosing and treating ischemic stroke is the screening process, finding these patients, okay? Now, while all cases of ischemic stroke are important, by far the most important subtype is large vessel occlusion, and that's where we're going to be using the screening tool, the Mango screening tool. This acts as a binary tool to determine whether or not we have a large vessel occlusion or not. Now, large vessel occlusion is very important. Why? Because although it only accounts for about 11% of all acute ischemic stroke cases, it's responsible for all acute ischemic related stroke death, 90% of societal cost, and 80% of poor functional outcome. So really, while this represents the minority of all acute ischemic stroke, this minority, this 11%, accounts for almost all the really bad stuff associated with acute ischemic stroke, meaning stroke death, societal cost of stroke, and poor functional outcome. That's why it's very important to identify who these people are and get them to the right hospital the first time so they can get the treatment they need. So STEMI heart attack, as you know, these patients go to a cardiac cath lab to get that blood vessel treated. In a similar fashion, a large vessel occlusion, acute ischemic stroke, has to go to the neurointerventional suite to open up these occluded vessels in the brain. Now, STEMI status is determined by an EKG. We don't have an EKG for the brain yet at the field. We determine large vessel occlusion status in stroke by neuroimaging, but there is a way to determine in the field who we suspect has a large vessel occlusion so we can confirm it later. So unlike STEMI, in the field we're clinically screening for a large vessel occlusion. Other things could be causing that, like a bleed or a tumor. And then we confirm those patients, confirm that large vessel occlusion when that patient comes to a comprehensive stroke center. Now, all large vessel occlusion patients must come to a comprehensive stroke care center because these are the centers that can perform 24/7 endovascular treatment. And why is that so important? Because these are the centers that can get groin access, go up into their brain with these devices, get across this clot and pull it out of the brain. And we have to be able to bring these patients to these centers to do so. And why is that so important? Because the larger this blood vessel is, the less effective IV TPA is. So while IV TPA is a great drug, it's not particularly effective in these very large vessels. That's why they have to go to comprehensive stroke centers. And really the key is to screen them, to find them fast so they come to a comprehensive stroke care center so we can fix them fast. And you might ask yourself, well, why would you go to a hospital that can't perform endovascular treatment? And sadly, that happens daily. But here's the problem. Look at this segment here in the green. This is penumbra or salvageable brain. Over time, this becomes a core infarct or irreversibly damaged brain tissue. Once we have a core infarct, irreversibly damaged brain tissue, we can't change this. This is a done deal. We need to intervene on the front end of this while we still have salvageable brain. And over time, as I said earlier, we lose this precious salvageable brain. That's because when a stroke occurs, the central portion of that stroke typically is a core infarct. This is tissue that's irreparably damaged, surrounded by a salvageable ischemic penumbra. This is what we're trying to save. And as I stated earlier, over time that core gets bigger and bigger and bigger, such that that core envelops that penumbra. When that happens, we lose the ability to have a good functional outcome and eventually have a poor functional outcome if we don't intervene quick enough. Some studies have shown when patients are incorrectly going to a primary stroke center and then transferred to a comprehensive stroke center, that could take over 2 hours. This is not the transfer time, it's the time it takes us to work up the patient, realize they have an LVO, and then go, oh, by the way, they're in the wrong hospital, let's transfer them somewhere else. This means 30 to 40% of patients with the large vessel occlusion that first come to a primary stroke center and then are transferred to a comprehensive stroke care center are no longer candidates because that penumbra is now irreversibly converted into a core infarct. That's why it's right to do it right the first time, to get that patient to the correct facility. And that's what Mango is. It's a rapid and reliable tool to allow you to identify a large vessel occlusion and get to the right center. Now, there are multiple screening tools out there, but really, if you look at the American Heart Association and Stroke Association, they're both basically saying we need better screening tools to identify people with large vessel occlusion stroke. And that's what MANGO is. So I'm going to talk about MANGO for one moment before we go on. What MANGO is, it's a screening tool for stroke. If you remember the word MANGO, the letters stand for motor weakness, specifically arm weakness. A is for aphasia, and we'll talk about the different forms of aphasia. N is for neglect, G is for gaze preference, and O is for optic field cut or new blindness, or actually any visual disturbance. So what MANGO allows us to do is quickly look at different cortical distributions in the brain. And if you take anything else from this lecture, just remember this one thing. To be MANGO positive, you have to have motor weakness and one other cortical distribution. That is, you have to have motor weakness and one other cortical distribution. You're hearing me say that over and over and over again. So let's look at MANGO and what it means. So when we start our evaluation, we look for M, or motor weakness. How do we assess this? We ask the patient to hold up their hands or their arms, palms up, for 10 seconds. If they're able to hold up their arms, palms up, for 10 seconds, they don't have motor weakness, they're MANGO negative. We just excluded a large vessel occlusion in 10 seconds. If, however, they have complete paralysis in their hand, they have severe weakness of the hand, they can't hold it up, they can't maintain holding it, any form of weakness at all in that arm, that counts as motor weakness. If they have motor weakness, then you go to the next letter, which is A for aphasia. There's two types of aphasia. There's an expressive aphasia, when it's difficult to produce language, and a receptive aphasia, where it's difficult to understand language. For expressive aphasia, I typically ask the patient something like, "What is this?" And they'll tell me, "That's a pen." I'll ask them, "What do I use this for?" And they'll tell me, "You write with it." That tells me they don't have an expressive aphasia because they clearly are able to express language, and they don't have a receptive aphasia because they understand the question I asked them. If you have any doubts, ask them to follow commands. Ask them to blink their eyes, close their fist, to make sure they don't have receptive aphasia. Remember, expressive aphasia is the inability to produce language. Receptive aphasia is the inability to understand language. But that's different from something else called dysarthria. So what is dysarthria? Dysarthria is motor weakness, but instead of involving the arms, it involves the mouth, or the muscles in your mouth and throat that produce language. So if I ask a patient, "What is this?" or "What is this?" they might say, "That's a pen." And if I ask them, "What do I use that pen for?" they might say, "You use it to write with." Now notice that they have that thickened, slurred speech because their motor function, their mouth, makes it very difficult to articulate. But at the same time, they're producing language, so they don't have an expressive aphasia. They understand the question you asked them. When you asked them, "What is this?" and they responded, "You use it to write with," they understand what you're asking them, so they don't have a receptive aphasia. Now, if they don't have an expressive or receptive aphasia, go to N, which is neglect. And the way I check for neglect is I ask the patient to close their eyes. I touch one side of the face and I ask them, "What side am I touching?" They'll say they're right. I touch the other side. I ask them, "What side am I touching?" They'll say left, and here's the key. Then I touch both sides together. Now, when you touch both sides together, they should say you're touching both. If they say left or right only, that's what we call extinction. It's another way to measure for neglect. So I check for neglect touching one side, the other, and then both sides of the face together with the patient's eyes closed. Then I check their arms and their legs. If they don't have neglect, look for gaze preference. Gaze preference, quite simply, is the eyes looking to one side of their hemisphere. So in this case, I would have right gaze preference. I'm looking at one side. It doesn't matter if it's voluntary or involuntary. It doesn't matter if you could go back and forth. As long as you have gaze preference, that counts as being positive. And by the way, that's one really interesting thing on MANGO. There's no subjectivity to it, and there's no adding or anything like that. It's a binary test. If they don't have neglect, aphasia, or gaze preference, go to O, which is optic field cut. So ask them to cover one eye at a time, or you cover one eye at a time, and check their visual fields, all four quadrants. If they have any visual abnormalities, double blindness, blurry vision, that counts also, okay? So start from the top with motor weakness. If they don't have motor weakness, they're not mango positive, we don't suspect they have a large vessel occlusion. If we test them for motor weakness and they have motor weakness, but they don't have aphasia, neglect, gaze preference, or an optic field cut, they're mango negative also. To be mango positive, as I said earlier, you have to have motor weakness and one other cortical distribution, one other aphasia, neglect, gaze preference, or an optic field cut. So again, to be mango positive, you have to have motor weakness or one other cortical distribution. Now, if you arrive to a scene and you see patients completely obtunded, they're passed out, they're knocked out, they're completely unresponsive, assume they're mango positive, okay? So with that, we're going to go on here. And as I said earlier, mango assesses for motor arm strength by asking to hold up their arms, palms up for 10 seconds. We're looking for aphasia, both expressive and receptive aphasia, neglect, gaze preference, and optic defect, whether it's a field cut, blindness, double vision, or any visual problem for that matter, okay? So when we look at this mnemonic mango, again, it starts with M for motor or arm weakness, then we're looking for aphasia, neglect, gaze preference, or an optic field cut. Remember, when you start with motor weakness, if there is no motor weakness, after asking to hold up their arms, palms up for 10 seconds, they're mango negative. You have just excluded an LVO. If they have motor weakness, but they don't have aphasia, neglect, gaze preference, or an optic field cut, they're also mango negative, because as I said, to be mango positive, you have to have motor weakness plus one of these other four cortical distributions. Now, mango's been derived from two other tests called VAN and ACT FAST. And what's very interesting, all of these tests look for those same areas of the cortex. They're assessing gaze preference, neglect, aphasia, and both of those tests demonstrated that both nurses in VAN and paramedics in ACT FAST could detect large vessel occlusion, acute ischemic stroke, these symptoms, almost as accurately with 100% and 97% accuracy to stroke physicians. And what are we looking at when we look at things when we're assessing a patient for mango? All we're looking at is these different cortical distributions in the brain. And as I said earlier, to be mango positive, all you need have is motor weakness plus one of these other cortical distributions, whether it's gaze preference, aphasia, neglect, or a visual field cut. So these are the areas we're looking at. We're looking at 6 cortical areas, one of which must be motor weakness, okay? So again, when we look for mango, we assess for mango, and we're assessing for large vessel occlusion, you have to have motor weakness and one other cortical distribution, aphasia, neglect, gaze preference, or an optic field cut. So I think everyone's seen this game here, Battleship, and if you think of mango's Battleship for the brain, you'll never forget it. So for those who have not played Battleship, the objective is, without looking at your opponent's game board, is locating where the battleship is, putting enough hits on that battleship, and sinking that battleship. So mango is playing Battleship, except we only have 2 points of interest. We're looking for motor weakness plus one other cortical distribution. So if you look at mango again, we look at motor weakness, we're assessing for motor weakness plus aphasia, motor weakness or neglect, motor weakness or gaze preference, motor weakness or an ocular field cut. So here's our Battleship board arranged in the same pattern as the human cortex, the brain's cortex. And if you look at the first category again, motor weakness, we're going to put a red peg in the motor cortex, all right? So we have motor weakness. So again, to be mango positive, we need one other cortical distribution. If we look at our chart here, the first cortical distribution we're looking for is expressive aphasia, Broca's area. You don't even need to know that this is Broca's area, but here it is. All you need to know is that there's motor weakness plus one other cortical distribution. So this patient is mango positive, you suspect of an LVO, they should go to a comprehensive stroke center. Here's our next case. Patient has motor weakness and now they have receptive aphasia. This is Wernicke's area. That's where that occurs on the cortex. You don't need to know that. All you need to know is that motor weakness and they have receptive aphasia, one other cortical distribution, they go to a comprehensive stroke center. Here's another patient with motor weakness, and look, the parietal lobe's involved. That causes neglect. You don't need to even know that. All you need to know is that motor weakness and neglect, 2 cortical distributions, off they go to a comprehensive stroke center. Here's another patient, motor weakness, the motor cortex is involved, And now the frontal eye fields are involved, which causes gaze preference. You have motor weakness plus gaze preference. Motor weakness plus one other cortical distribution, this person is mango positive. Finally, we have motor weakness here, and now the visual cortex is involved. This person has a field cut. Motor weakness, one other cortical distribution, this person goes to a comprehensive stroke center. So again, to be mango positive, a motor weakness plus one other cortical distribution. Let's look at this guy. This guy has motor weakness, but look at this. No other cortical distributions here. So you must have motor weakness plus one other cortical distribution. This person is not mango positive. We do not suspect an LVO. They do not need to go to a comprehensive center. So again, to be mango positive, you have to have motor weakness and one other cortical distribution. This is the most important slide of this whole lecture. To be mango positive, you must have motor weakness plus one other cortical distribution. So again, when you assess for mango or large vessel occlusion, acute ischemic stroke, if they're mango positive, you suspect an LVO, you go to a comprehensive stroke center. If they're mango negative, you don't suspect an LVO and they could go to a primary stroke center. Again, if they could go to a comprehensive stroke center within a reasonable period of time and they're mango positive, you suspect an LVO, take them to a comprehensive stroke center. Now what's very interesting is we are now using mango in the hospital as well as our pre-hospital screening system with EMS. So now when EMS is coming into the hospital and they tell us it's mango positive, we are alert, vigilant, and ready to take care of these patients. The best way I can explain this is, when I used to work in the hospital, I used to hear stroke alert, stroke alert, stroke alert all day long. That means absolutely nothing to me. I don't think it means anything to anyone else. But now when we hear mango alert, we know patients come in the hospital with a suspected large vessel occlusion. We go to the lab, make sure our team's ready, all our supplies are ready, and we're ready to treat what will likely be a large vessel occlusion. So again, mango is binary. If they're mango positive, yes, you go to a comprehensive stroke center. If they're mango negative, no, you don't. You need not go there. Again, we're doing an IRB in both hospitals in Naples right now to confirm the validity of this screening system. But in conclusion, it's very important to understand that these large vessel occlusions, while they can respond to IVTPA, the response rate is far greater for mechanical thrombectomy. And that's why we need to take these patients to centers 24/7 that can perform this procedure, pull this clot out of the brain and restore blood flow to the brain. It's very important we do that. It's very important we recognize large vessel occlusion, acute ischemic stroke. Why? Because while this is only 11% of all acute ischemic stroke death, again, it's all acute ischemic stroke related death, societal cost, and 80% of poor functional outcome. That's why we have to identify this subset of patients so quickly. And that's what this pre-hospital phase assessment, why it's so important to utilize a rapid and reliable screening tool like Mango to get them to the right hospital the first time, because the clock is ticking. Remember, we do not want to waste any of that valuable time where that penumbra becomes a core infarct. So again, to be Mango positive, you have to have motor weakness plus one other cortical distribution. Now let's look at this example here. This patient, right off the bat, has left arm weakness, all right? And they have gaze preference to the right. Is this person Mango positive? I hope seconds after I asked that question you answered yes, because here we can see that the primary motor cortex is involved, so we have motor weakness, and we have gaze preference. That's another cortical distribution. So what do we have? We have motor weakness plus one other cortical distribution. That's all you have to be Mango positive. So there's only two things you have to remember from this lecture. To be Mango positive, to suspect the patient has an LVO, you must have motor weakness plus one other cortical distribution. You must have motor weakness plus one other cortical distribution. Remember, Mango is like Battleship for the brain. If you understand how to play Battleship, you understand how to use Mango. Because to use Mango correctly, you just have to recognize that that patient has motor weakness and one other cortical distribution. You suspect an LVO and take them to a comprehensive stroke center. One last thing we're going to talk about here, and that is, in the community, they recognize the signs and symptoms of stroke. They call 911, 911 dispatches EMS, they go and see the patient. If they're Mango positive, they send them to a comprehensive stroke care center. If they're Mango negative, they take them to a primary stroke care center. But this is the rate limiting step of this pathway. That is the community being able to recognize the signs and symptoms of stroke. And this is where we really need to up our game with the community. We have to review the signs and symptoms of stroke so they understand what the signs and symptoms are, and equally as important, they understand they have to get to the hospital as quickly as possible, so you have to recognize the signs and symptoms of stroke and dial 911. And if they do that, you guys will pick them up, or EMS will pick them up and bring them to the hospital so we could treat them. Again, to be mango positive, we must have motor weakness plus one other cortical distribution. This whole lecture can be summarized in this one slide. You must have motor weakness and one other cortical distribution involved to be mango positive. If you can do that, you could find them fast so we can fix them fast. Thank you very much.